I'm Mark Levis. I'm here at the ASCO meeting 2018 in Chicago, and I'm talking about our presentation of our trial in progress, which has a long name, and I'll summarize it as BMT-CTN 1506, also known as MORPHO, in which we are studying gilteritinib, a FLT3 inhibitor given as maintenance versus placebo for patients with FLT3-ITD AML who have undergone an allogeneic transplant. And the nature of this trial is, I think, this is a very important trial in my view, because we are in general agreement worldwide that a patient with FLT3-ITD AML should undergo an allogeneic transplant for their best chance at a cure. However, the practitioner has got that patient in front of them after their transplant, and there is this concept that patients should be on some form of maintenance therapy. Now, it's interesting. That seems logical. They should be on a maintenance therapy. Everybody knows this, but in fact, they really don't know that. We make a lot of assumptions in medicine based on what seems logical, and we really don't have all the variables. And honestly, the best way to answer the question is a properly designed placebo-controlled trial. So is it ethical to do this? Yes, it is, in my view. I think we truly don't know the answer. We don't know the ramifications of long-term treatment with a FLT3 inhibitor in somebody who ostensibly is cured. We would like to know who truly needs one. So this trial, I think, is designed to answer all of these questions. We've chosen a drug that is going to be indistinguishable from placebo. So a patient's not going to know that they're on it, and neither will the investigator. One of the key endpoints of this trial is not just relapse and survival, but it's measurable residual disease. So the patient who's been transplanted, are they cured, or do they still have a residual leukemia stem cell with the mutation present? We've developed an assay where we think we can detect this. If successful, the patients who are randomized to gilteritinib, which is the study arm, if they have detectable mutation, then we would predict that they're not going to relapse. If they do not have detectable mutation, okay, great, the drug in theory is doing them no good. So that takes us to the placebo arm. If a patient does not have detectable mutation by measurable residual disease assay, and they don't relapse, we've just found the population that doesn't need the drug. And so we're going to have a trial randomized that at the end of the day will say, does the drug prolong survival in this population versus placebo? Great, but we'll also be able to identify who benefits from it and truly select who should be on the drug. So we think we're going to learn quite a lot from this study, and we're quite excited about it. It's accruing, I want to say, approximately 20 countries worldwide. The accrual target is around 350 patients, and we're accruing nicely as of this time.